Health and well-being are subjective and not universal as we think in Western countries. Their perception is influenced by cultural factors, having a strong impact on treatment accepted. These peculiarities may hinder the achievement of global sustainable goals, therefore should be deeply understood and maximally considered before introducing novel medical practices. Animist beliefs linked to mental illness persist among some populations in the Western countries of Sub-Saharan Africa. In those countries, those who manifest mental disorders are considered possessed by demonic spirits capable of causing harm to other individuals, to the family and the community. Therefore, insanity is considered contagious and the patient is ostracized by the group. It is common to meet mentally ill people on the street, abandoned to themselves, often naked, who are looking for food by digging in the garbage. A more cruel practice, unfortunately still in force, is chaining. Many families, fearing the unpredictability of the behavior of the mentally ill member, decide to chain them, immobilizing their limbs by fitting them in wooden block or imprison them in caves hidden from everyone's scornful look. There's no way out, no cure, if not dying from infections due to source natural causes or for animal attacks. No one dares to touch or get close to any person considered possessive. Everyone fears. For the past 30 years, Gregoire Ahongbonon, a tile mechanic from Benin, Sub-Saharan Africa, has started denouncing this traditional practice of treating mental illness according to traditional beliefs. The ethical dilemma that arises is how to overcome such fundamental tradition for the identity of the family when they can be ethically considered not human. A thoughtless intervention may have worse consequences, I think killing. Gregoire has found out his own way, mediating local culture with human rights. Can we adapt this method to other global health challenges? Can we use Gregoire's approach for other health technologies which are even more far from the traditional African medicine? What will be the result of this thoughtful approach if applied to medical devices? After the experience with Gregoire, I broadened my research and started a fellowship at the University of Warwick in the UpSpy Lab Applied Biomedical Signal Processing e-Health Lab. The lab commitment to low and middle-income countries is to find technical and political solutions related to the possibility of improving health technologies in developing countries, considering the specificity of contextual realities.
When it comes to low-resource settings, everything we know regarding the safety of medical devices and healthcare settings is no longer true. In the high-income countries, such as in Europe, we safeguard medical device users and patients by following strict international standards, which are then translated into national minimum requirements in each country. As an example, the air filtration level in a surgical theater in Italy should be over 99.97%. These kind of requirements are unrealistic for low-resource settings, where I've seen inadequate or absent air filtration. Such settings also face different challenges like unreliable power supplies, lack of spare parts, consumables, funding and expertise, and harsh environmental conditions such as dust, humidity and high temperatures. Is it possible to stretch the standards and make them more inclusive of all the different conditions that can be found around the world? Is it possible to make the design of the current medical devices more resilient and contextualized to the local needs? Scoping local needs and local contexts should indeed be the first step. This is why we have run 8 field studies in the past 2 years across Sub-Saharan Africa, specifically in Benin, Uganda, Ethiopia and South Africa. During these field studies, we were able to observe and assess the conditions of local healthcare settings and of all the medical devices. On the one hand, we used different instruments to measure the reliability of the power supply and the electrical safety of some medical devices. On the other hand, we have interviewed healthcare staff and biomedical engineers and technicians in order to assess the conditions of local hospitals. We have also been involved in design schools, where I've been mentoring a group of students towards the design of a prototype of a medical device using additive manufacturing and Arduino boards. However, it is important not only to support in local capacity building, but also to give the opportunity to experience the research in international universities in higher resource settings, where incoming students and researchers can leverage on advanced labs and various resources to improve their knowledge and work for their country's development. My colleague Busola Oronti, who is from Nigeria, is an example of this.
My name is Busola Oronti. I came from Nigeria about a year ago and started my PhD with Dr. Pecchia. I am currently researching into novel solutions for detecting, diagnosing and managing cardiovascular diseases in resource-limited environments, with particular emphasis on artificial intelligence, 3D printing and Internet of Things technologies. Employing artificial intelligence methods and solutions are especially desirable in low and middle-income countries because of the acute shortage of human resources for qualitative and quantitative health delivery, inadequacies in health infrastructure. I had my first trip to Benin Republic in November 2019, and the experience confirmed the existence of similar issues we are facing in Nigeria in the health sector. Beyond this, several underlying challenges that must be tackled by the collective will of the African people. Obviously, the formulation and firm implementation of the right policies and regulations, coupled with the impartation of knowledge and skills in technologies and tools required to manage and eventually develop more effective and affordable medical devices and interfaces for the African region is without question. All in all, to safeguard the universality of health and health technologies, we should not neglect the particular realities, but should take them into consideration and find a mediation with human rights. The real challenge for the future, in fact, is to aim for universal health coverage while respecting the peculiarities of the situation, as long as they do not harm the guarantee of universal human rights.